Now, another example is older people. I'll say the obvious, there's going to be a lot more older people. This is to do with South Australia, this slide, but it could be, South Australia is a bit older than the national average, but it's be repeated. And we have the confounding problem that whereas older people, say, fall and break their hips, they've only got 2 hips, they've got 32 teeth or some number of teeth, so it's more people and many, many more teeth that need maintenance and support. Much fewer people having all their teeth taken out in the past. In fact, almost no one's being made fully toothless these days. So that trend is solidly set. And many people enter older age after many, many years of compromised dental care. So that foundation for good oral health in old age is not there. So attention is needed in the broader community for a foundation for oral health in older stages. But I'm going to focus on the issues of the needs of older people from where they are now. And we use this continuum as a way of describing it, moving from community living, ageing well, community living, ageing frail, as cognitive impairment sets in and they need more support to stay community living, and then moving those that move to residential aged care, needing much more support in many ways, including oral health. Firstly, we started with a project to do with the community ageing well group. This program was, again, some of the same themes coming through. We wanted to see if inclusion of an oral health screening in a general health assessment, the EPC actually, assessment process, and timely dental care flowing from it could make a difference. Building on existing programs again, not trying to create a new world, and building capacity in this sector, the sector that looks after the community living well group. Now, we included a simple 6-question screening tool, very simple, I'll show it to you in a second, built on the EPC assessment process for people 75 and older, younger people for Aboriginal, of course, and then referring those identified for treatment, and if they were low-income earners, they could get their dental care from the public sector and bypass the waiting list. To see what would happen if you did that. And this is just a kind of a picture of a practice nurse applying this assessment tool in a home setting where these things often took place. Here's these 6 questions. I don't know if you can see them, but they aren't rocket science to say the least. Pain chewing, treatment needed, interrupting meals, difficulty relaxing, not complex, but they were shown to be predictive of people that did need attention. These people were at risk. Now, I'll cut a long story short by showing you one graph, which was a distillation of what happened pre and post intervention. So these people were assessed by the doctor or the registered nurse as being at risk using those questions. They were referred for priority treatment. They received their priority treatment. And the oral health impact profile is a distillation of answers to questions about how much the oral health is impacting on the day-to-day ordinary life. It's not about the oral health questions, it's about the day-to-day life of these people. How much has their life been interrupted and disrupted by poor oral health? And on the left, it's the pre-intervention OHIP score. In other words, oral health, poor oral health is impacting far more than the Australian average, which is that black line down near the bottom, on their lives. Post-intervention, they were down within the national average for the people in that age group. Significant impact on people's well-being. And we were astonished the impact was so great. Such a simple thing to do for community living older people with oral health problems made such a difference to their life. Now, we didn't test it, but I can't believe that wouldn't have made a contribution to their ability to stay well and living in their own homes. And so, 6 questions, 5 minutes extra on a 90-minute general health assessment, very low resource cost, and furthermore, more questions that were answered yes in that screening tool. In other words, more things were wrong, the greater the benefit in improving oral health in terms of the outcome. So there's kind of a dose response there. Very successful program. But then we move to the frail aged. This is people, the domiciliary care programs, the aged care assessment team people. We're dealing with these people already, and we weren't. And so, again, building on this process, the middle group there, building on this process, we want to integrate the oral screening into existing community assessments. And we want to therefore support oral hygiene in the home and then refer for treatment as needed. Now, we had a false start. We went down this dental silo model initially. We had dental hygienists doing some of these assessments and things like that. And then we realised this wasn't going to work because it would be better to build the whole process right into the existing system. In the case of our metropolitan domiciliary care and aged care assessment team type people, the assessment of ability to self-manage oral hygiene was better done by occupational therapists. One of the activities of daily living. You know, if people can't hold a knife and fork because of arthritis or whatever, they probably can't clean their teeth. There's a relationship between the oral health issues and the general health assessment issues. Oral health care plan by occupational health and safety therapists as part of the overall care plan. And then who implements the care plan, oral health, oral hygiene support and treatment depends on the needs. We produce resources and training to assist this process. And then evaluation showed that it was well received by the occupational therapists and PMAs. Again, using the same OHIP-type score, significant improvement in well-being, general well-being, as well as oral health. And then people in residential aged care, the right-hand side. This is common in residential aged care where people are not supported in their oral hygiene. I won't show you a litany of those photographs, but they are common. So the same process. We designed this in collaboration with the sector, a sector we knew very little about as dental people. They were completely involved in that process as well as the registered nurses and the GPs and the works. And an oral health assessment toolkit was developed and tested with Commonwealth funding support. Initially, a CD-ROM training manual was developed, a resource manual, a pocket guide to use in the field. It was tested in nursing homes in Adelaide initially with that Commonwealth funding. And it was very satisfying and pleasing to see how building on that existing capacity that was already there, adding the oral health bits was not that complicated. In the initial process, the GPs used the assessment toolkit, and we found that their assessment of oral health and the care plan agreed well with what was the gold standard of what the dentist said about that patient, which was tested in parallel. So we knew that that process was actually identifying the right people. Subsequently, we led a three-state Victoria, New South Wales and South Australia program to test this process in a broader range of settings to see if it was sustainable. It is. And the oral health assessment, the care planning done by the GP or RN now added into the equation. Daily oral hygiene implementing part of the care plan by the care workers. Referral for treatment in our version of the program, referral for the treatment when needed. An evaluation showed it was well accepted by the GPs, RNs and care workers. Good agreement between the assessor, dentist and the care plan that was developed. And implementing the care plan in this trial made it, again, the same issue, the same major difference to the well-being, general well-being of these people, not just the oral health issues that dental people care about. And this is just an example of it taking place. One of our steering group members and in a nursing home recently. So, in conclusion, workforce reform that works. We've found that if we develop our programs in collaboration with the sectors we're dealing with, not in the silo, tremendously important. Building on the existing non-dental workforce skills and processes was the key to success in these projects. Keeping it really simple can be done, and it works. The screening, assessment, care planning, support for oral hygiene and referral are the key components in each of these processes, and evaluation to show when things aren't working. And it's been one of the most rewarding things that our service has been involved in the last 4 years. In fact, I'll two of those projects I've just described to you have won Premier's Awards because they've been so successful, and some of the members of the team that have done this work are here today. Thank you very much.